Very pleasant good afternoon to all of our viewers and welcome to another edition of Let's Talk. We are delighted that you have chosen to join us on this continuing discussion on taboo issues, particularly dealing with women. And this afternoon, we are discussing a very important subject. We are dealing with the subject of breast cancer. As some of you may know, that October is Breast Cancer Awareness Month. And as we are dealing with issues relating to women, we thought it would be a great idea to talk about breast cancer. We have two very important guests lined up for you this afternoon. Before I introduce our guests, however, we'd like to invite you to have a word of prayer with us. Father, be with us as we go into this afternoon's discussion. We pray for your wisdom, your grace, and your guidance. Take full control, have your own way, and grant us your peace and your wisdom as we discuss this very important subject, a subject that is sometimes very little understood, and still, in spite of all the publicity, a lack of knowledge across the landscape. But we pray that the program today will make a difference. Be with our guests and grant them wisdom as they respond to the questions. In Jesus' name, amen. Amen. My friends, as indicated, we have two special guests with us this afternoon as we are discussing breast cancer. I want to let you know that we have an oncologist who, by the way, is on call. And so from time to time, he may have to interrupt a little bit to deal with some matters. And we have also a surgeon who either is preparing to go into surgery or just came out of surgery. And so this afternoon, we are grateful for their time. I want to begin by introducing to you at this time our first guest, who is the oncologist. He is Dr. Hannibal Yazigi. I have to practice that name.
That's perfect.
All right, wonderful. He's a consultant, medical oncologist at the Sir Lester Bird Medical Center here in Antigua. An Antiguan by birth, studied in Cuba. So he is very familiar with the local situation and local circumstances. He has written and participated in various published academic studies and continues to expand his academic portfolio. Currently, he is conducting retrospective descriptive studies in the prevalence of multiple cancers in Antigua and Barbuda. I'm going to be looking forward to reading about that when those studies are done. But we're delighted to have with us this afternoon, Dr. Hannibal. If you don't mind me calling you by your first name, that would be fine.
That's fine.
A little easier.
That's fine. Thank you.
Welcome to Let's Talk and good afternoon. We also have.
Thank you, and thank you for having me, sir.
Yes, we also have with us this afternoon a surgeon in the person of Dr. Goodwin. Dr. Goodwin is joining us. I believe you would notice that he is looking like he is either preparing for or coming out of surgery. For a moment, I thought he would not be with us because of an appointment that he had. But we're delighted that he has made the sacrifice to be with us today. Just let me tell you a little bit about Dr. Goodwin. He is born and raised in Antigua and Barbuda. And in 2006, he went to the Republic of Cuba to undertake the task of becoming a medical doctor. Returned in 2013, so both our doctors this afternoon know a bit of Spanish. He has been at the Sir Lester Bird Medical Center as a general surgeon. After 4 years of residency and training, he again in Cuba, he returned to Antigua where he continued his work, but now in a greater capacity on the general surgical department as a consultant general surgeon. We are delighted to have you with us, Dr. Gordon. Good afternoon and welcome to Let's Talk.
Good afternoon, everybody, and thank you for having me on.
Well, I'm delighted to have you two gentlemen with us today. We are going to begin the conversation by talking about breast cancer. That's our focus for today. And you may observe that Dr. Yazigi has the Breast Cancer Awareness Month logo at the back. So he is a big promoter. In fact, it looks to me as though his shirts is also talking about breast cancer. Is that correct?
Yes, this shirt is in support of Walking for a Cure. It's actually a shirt that I got last year from a walk that we conducted here, sponsored by CIBC Bank, which, if you can see, it's the purple ribbon, which is representative of cancer awareness and in general, and a fight for cure for cancer in general, which is why I chose to wear this shirt and have the pink background, so we can touch upon everything.
Yes, very, very appropriate indeed. Well, gentlemen, I want to jump right into the discussion. 1 hour goes by very quickly. So before we deal with the specifics of breast cancer, though, let's just, if you could explain what is cancer and why should people be concerned about it? Do we start with oncologists? Yes. Go right ahead, Doc.
I missed that last part. My connection lagged for a second.
I was asking, what is cancer and why should we be concerned about it?
Okay, all right. So, hello everybody. What is cancer and why should we be concerned about it? So, cancer is nothing more than the rapid division of cells that once were normal but became mutated. Their genetic code becomes mutated because of factors like smoking, for example, or using hormone pills, radiation, etc. It damages the code that governs the way that the cells behave, and it causes them to start to reproduce much quicker than normally they would. And it gives them the ability to evade our immune system, which is in charge of controlling that proliferation and killing them before they can become cancerous. However, sometimes these cells are able to develop mutations that make them immune to these mechanisms, and therefore they acquire characteristics which enable them to not only reproduce quicker, but also to spread and to destroy neighboring structures. For example, if a breast cancer, a breast cell becomes mutated and becomes cancerous, it has the ability to grow exponentially and to destroy the breast tissue around it, and even to spread to lymph nodes in the axilla or other organs as well. So that is what cancer is, and we should be definitely concerned about it because it is, as of this year, the second most common cause of death worldwide in general, and it is seen to become, it seems like it could become the #1 cause of death worldwide in general by the year 2035, actually 2030, 2035.
Okay, that is very interesting. Later in the conversation, we will talk about some of the causes. Now, you mentioned a couple of things there. We will expand on those a little more, but it is interesting that you spoke about cancer spreading in the lymph node, and we ought to be concerned about it because it is, you mentioned, the second leading cause of death. And I know that life is precious and that people don't like to harbor the idea that something is going to result in their death, but that is one of the reasons why we want to highlight this afternoon this matter of cancer. Now, we are talking about breast cancer, and October is considered Breast Cancer Awareness Month. So is breast cancer just a matter of where the cancer is located, or is there something else to it? Because I hear of several kinds of cancer. I hear people talk about breast cancer, prostate cancer, lymph, colorectal cancer, and so on. What about breast cancer?
Sure. So as you just said, cancer can arise in any tissue and any part of the body. And the type of cancer that we deal with has a lot to do with the cell that becomes cancerous. So if a cell from the breast becomes cancerous, then we're dealing with a breast cancer. Even if it spreads to the liver or to the bone or to the lung, if it arose primarily in the breast, or meaning it comes from a breast cell, then it would be classified as a breast cancer, regardless.
Okay, so that's interesting. So irrespective of where it is manifested, once it's the origin is from the breast. Okay. Dr. Gordon, you are Goodwin, sorry, you are a surgeon. Do you encounter breast cancer cases locally?
Yes, quite regularly. I've been back working in Antigua for almost 4 years now, and a very large portion of the work that I do does include patients that have breast cancers. And a lot of the patients I end up dealing with at some point in time, I end up consulting along with Dr. Yazigi and the other doctors in the oncology department because of this breast cancer.
So when we think about breast cancer, just a follow-up question, Dr. Goodwin, when we think of breast cancer, we generally think of women. Does breast cancer affect men also?
Well, the simple answer is yes. Some people might think that it's only a female problem because you only see quote unquote breasts on women, but in reality, the tissue that becomes the breast anatomically as somebody develops from the prenatal stage into adulthood, that tissue is existent both in male and female fetuses. The problem, or rather the difference, is that during puberty, different hormonal changes in the body cause the tissue within the area of the chest to develop in different ways between males and females, more so in the females and less so in the males. But the base tissue, or the cells that are present in the chest area still do exist, and technically breast cancer can arise in men, although it is comparatively much rarer so than in women.
Okay. Doc, you want to add anything to that, Dr. Hannibal?
No, that pretty much sums it up. The only thing I mean, I like numbers, because in oncology we do deal with numbers a lot. And just to put it in perspective for everybody, breast cancer in men comprises, even though, as Dr. Goodwin said, a lesser percentage, it is still seen in men, and that would make males. The male cases arise in only 1%. So basically, 1% of the breast cancer population is male.
Okay, so that is just to confirm that the prevalence in men is a lot less than in women.
Right.
Now, this question, we often hear of lifestyle diseases, and sometimes I hear people putting cancer there and sometimes they don't. To what extent is behavior, lifestyle associated with cancer? Are we more or less likely to get cancer depending on the lifestyle we live in? And how does this relate to breast cancer?
Okay, so breast cancer is, or you have lifestyle diseases, as you said. Breast cancer could be classified as a lifestyle cancer in a certain subgroup of the general population, mostly in women who practice celibacy, like nuns, for example. It used to be known as a disease of the nuns, right? Back when there wasn't a lot of studies being put into it. I mean, in the late 1800s and early 1900s, they used to call it the disease of the nuns, because it has a lot to do with breast cancer has a lot to do with estrogen. All right, it's at the mercy, so to speak, of the amount of exposure of estrogen that a woman is exposed to during her lifetime. And women who don't bear children, don't breastfeed, usually are exposed to estrogen for a longer period of time, because estrogen levels decrease significantly during pregnancy and during breastfeeding. So also women who experience an early start in their menstrual cycle, meaning they start before the age of 12, And those who experience menopause after the age of 55 have a significantly higher risk. So that's why nuns who have never, had husbands, never became pregnant and never breastfed, they saw that breast cancer arose in nuns a lot more frequently than in the average married woman. So they used to classify it as a lifestyle disease, but nowadays, where women are more in tuned with, bettering themselves professionally, going to school, postponing marriage and childbearing to later ages, we see it more evenly distributed throughout the population.
Now, those are some interesting observations there. And I want to pick up on one thing you mentioned, and that is the matter of breastfeeding. Now, I've heard, now we have addressed breastfeeding on this program before, but I've heard women say one of the reasons they don't like to breastfeed is because they don't want to lose the shape of their breast. Are we saying that to even to become pregnant and to have a child and not breastfeed is increasing the chances of breast cancer? Can I conclude that?
Yes, Dr. Greene. Actually, you see, even as a pastor, as a doctor in theology, you would know that vanity is a sin, right? So the Bible is very wise when it addresses vanity, and at least when concerning breast cancer, because I do hear the same thing. Women don't want to breastfeed so they don't lose the shape and the turgidity of their breasts. But actually, medically speaking, and the way our bodies are created or are composed, breastfeeding helps to mature the breast tissue, and that tissue is dense and abundant when you're young, so that you can breastfeed with it. That's the purpose. It's that dense, and the purpose that the woman breastfeed is to decrease. Also, one of the reasons that breastfeeding helps is because it decreases the amount of fibroglandular tissue in the breast, matures it, and the less cells or the less active breast cells that a woman has, the less likely that one of these cells, because of quantity, just as logic would say or would suggest, the less cells you have in the breast, the less likely you are to develop breast cancer. That's another factor.
Now, I want to go back to the question here, and I don't know if Dr. Goodwin wants to comment on it, because my original question was about cancer as a lifestyle disease, and I was asking whether people are more or less likely to get cancer depending on their lifestyle. So one matter, I mean, we can be specific with whether or not you choose to breastfeed, but are there other lifestyle practices that make people more prone to cancer?
Well, that's a very broad question. Cancer can have various known causes, and we still don't know all the causes or all the elements that can cause cancer, but lifestyle has been demonstrated to be a major factor in not only breast cancer, but many other types of breast cancer. Specifically, one of the ones that we always tell people about is smoking. Cigarettes contain a myriad number of different chemicals that we call carcinogens. Carcinogens are chemicals that tend to cause the development, production, or growth of cancerous cells within normal tissue. Apart from that, there are other factors that you can include in lifestyle changes. For example, lifestyle factors such as use of birth control medication and use of other types of medication that can contribute to the propensity of cancer, for example. Like Dr. Yazigi was rightly describing earlier, the longer somebody is exposed to certain types of hormones, the more likely or more possible it is for someone to develop cancer over time. So the way hormonal birth control does it alter the chemical composition or the hormonal the hormonal balance of your body, and that while it might give you the benefit of preventing a pregnancy, it could cause potential problems further down the line.
And now you doctors are raising some issues there that I'm so tempted to go down that road, but I want to get back to breast cancer. So let's not yield to the temptation. So let's get back to breast cancer. and talk about the specifics now, a little more specific. So we understand that lifestyle can contribute. We understand that the time you know breastfeeding, refusal to breastfeed can contribute. I see some women on the side of the road barbecuing, and they seem to be sitting there in all of this smoke consistently, you know. Is that a factor? I didn't call a name, but Dr. Yazigi, you can respond.
Sure. I mean, smoke in any way or form is a very big risk and a very big risk factor in things like lung cancer. It can increase your risk of developing any cancer, including breast cancer, but it's not as prevalent as a risk factor in breast cancer as it is in other things like lung cancer, lymphomas, bladder cancer, colon cancer, especially smoking cigarettes. But you're referring to the ladies who are selling barbecue. And yeah, it's not as big of a factor in breast cancer as it is in other things, basically.
Okay. Now,
if I might interject there and do add what you brought up, the subject of selling barbecued and other things like that on the roadside. Some studies have demonstrated that overly cured meats and heavily cured meats and barbecued meats do actually contain, like I mentioned before, certain substances or certain chemicals that also can increase one's chances of developing a cancer, not specifically breast cancer, but cancer in general over the course of their lifetime.
okay.
Yeah, especially GI cancers like gastric and colon cancer and intestinal cancer. That's
Yeah,
true.
I'm going back a little bit. I do anticipate that we have a lot of women who are listening. I did encourage the men to listen because they play a vital role, supportive and otherwise. But I want to go back, and I know I'm straying a little bit, but I want to go back to both of you raised the issue of contraceptives and the hormonal balance in the body and what it can do. These days, especially when people seem to be very concerned about the number of children that they have. And some people want to delay pregnancy until they're through with their studies. A lot of professional women who are choosing not to have children or getting married late. And some may get married early, but don't want to have children. And so one of the things I do when I do premarital counseling is that the counselees have to research the contraceptives that are on the market, and one of the aim is to get them to understand, you know, if I use this one, what it does, what are the side effects, etc. As medical practitioners, how concerned should a woman be with respect to knowing walking into a store and purchasing, I don't know if they're readily available, but contraceptive pills, or deciding to take injection or use a patch, something. Do you advise them to consult their physicians and get guidance as to how these may play out in their lives afterwards? Dr. Gordon, you want to go? Or next time I ask a question, I'm going to call a name. Dr. Gordon, go ahead. Goodwin, sorry. You're muted.
I'm sorry. I've had a bit of a problem with the connection there. I didn't hear the tail part of the question. I heard it. What degree of concern could one have regarding the use of certain substances, certain medication?
No, I was asking specifically about contraceptives and their impact on a woman. So should a woman consult her doctor before deciding on what kinds of contraceptives they use, with respect to the impact they can have on her?
Well, yes, it is always wise for one to consult with their doctor before starting the course of treatment with any medication. But I can say that there are multiple different kinds of birth control. There are hormonal birth control methods. There are barrier control methods, such as the use of male and female condoms. And there are other methods of control, such as surgical sterilization. For example, some women might opt to have something called a tubal ligation, These are all different modes of birth control, and each one has its pros and its cons, depending upon one's plans for the future, whether one might want to have children in the future or not. One of the hormonal options or the barrier options might be more viable for the purpose of birth control at that period in time compared to someone who does not plan to have any children in the future. And in that case, a surgical option would be safer in terms of avoiding the problems that one comes across regarding the future potential for cancerous issues. So yes, my advice is one should always consult very deeply and very widely with their doctor before starting any medication.
Now, Dr. Yazigi, if a woman discovers that she has breast cancer, we're going to talk about what she needs to do in terms of checking, but or let's say a woman listening to this program this afternoon, maybe she's not married and she's listening and she's thinking, oh boy, if I don't want to be like the nuns. How concerned should a woman be with respect to breast cancer?
Okay, so there are average statistics that suggest that 1 in 8 women will develop breast cancer before the age of 70. All right. There are other studies that say most women will develop some sort of breast mass before 70. And that is an alarming number because 1 out of 8 is around 12.5%. And that is so to speak, if you can count 10 women off the top of your head, family members, friends, likely 1 or 2 of these women will develop breast cancer, and maybe 7 or 8 of those women would develop some kind of breast mass or breast lesion, whether cancerous or not, during their lifetime. Also, just to add to a point and just to clarify a point when we were talking about OCPs or oral contraceptives, there are different types of oral contraceptive pills. As Dr. Goodwin mentioned, in general, there's different types of contraception. When we're talking about hormone pills, there are 2 female hormones we deal with, progesterone and estrogen. And depending on the quantities of these 2, the risk of the breast cancer risk increases when there's more estrogen than progesterone in the pill. So when we say usually birth control pills contain more progesterone than estrogen, but the combination pills or the ones that contain both carry a slight risk for breast cancer. So yeah.
Okay, so women need to pay attention to these kinds of things. So is the discovery of breast cancer a death sentence?
No, it definitely isn't, and it depends on the stage, of course, more than anything. So when a breast cancer is diagnosed at stage 1 or 2, the general consensus worldwide and the studies that we've compiled, especially in recent years with the recent advances that we've developed in the field of oncology and cancer treatment, breast cancer treatment, stage 1 and 2 breast cancers have a 5-year survival rate of about 98%. So 98% of women that are diagnosed with a stage 1 or 2 breast cancer would live to see 5 years, and about 92 to 95% of the same patients live to see at stage 1 and 2 would live to see 10 years at the 10 years. So, and it is very important to keep in mind as well that the 2% or the 5 to 7% at 5 and 10 years that do pass away, not all of them do pass away because of complications related to breast cancer. Some may just pass away because of old age or heart problems or other causes, right? So that would further show you that breast cancer is not a death sentence. And now if you look at stage 3 and 4 disease, women who present at stage 3 disease or locally advanced, I'll get into, if you would like to know later on what the stages mean, etc. If the patient is diagnosed at stage 3, they have a 5-year survival of around 87%, and this drops drastically to about 76% at 10 years. Whereas stage 4 diagnosis at stage 4 carries a much poorer prognosis, where women have a 5-year survival rate of around 10% and almost 0 at 10.
Interesting. You kind of read my mind because I was going to ask you to just to say a little bit on the stages, just for the benefit of all viewers, because we have all kinds of people who listen. And I often hear, this person has stage 3 cancer, or this person has stage 4 cancer. What's behind the stages?
Okay, so we use something called the staging system, called the TNM staging system. T for tumor, N for node, and M for metastasis. All right. When we talk about tumor, we talk about tumor size. And the T stage is, or the T factor in staging, goes from TIS, or precancerous lesion, meaning a lesion that's not yet cancerous, TIS, all the way to T4, which is a tumor that infiltrates or is growing into the skin or the muscle, the chest muscle behind the breast tissue. Then we have nodes, where we talk about lymph nodes. Those are lymph nodes in the axilla and inside of the chest, in the middle of the chest, called internal mammary lymph nodes. Those are classified from N0 to N3. All right. And M is talking about metastasis. If you would allow me to share my screen just briefly, I can show a poster I have here.
Sure, that's okay.
Is that okay? All right.
Fine.
How do I share with this? Can we share using this platform, sir?
Yes, at the bottom of the screen, you just beside, yes, I think you
Can we see here what we're looking at?
Yes.
Okay, so as you can see here, sorry. So as you can see here, stage 0 is when the cancer is not yet cancerous, or the tumor is not yet cancerous. It still hasn't started to spread into the tissue around it, so it's still localized, it's encapsulated. But it is cancer, but it's encapsulated, it can't spread. Surgery and radiotherapy and hormone therapy usually suffices in that. Okay, so now when let's go to this one. Sorry, we're talking about staging. So 0, the tumor size is very small inside the gland. There's no cancer in the lymph nodes, and it's confined to the breast. And the survival rate is about 100%. Okay, the 5-year survival. Sorry about that, guys. In stage 1, the tumor is less than 2 centimeters in size. There's no lymph nodes. There's no cancer in the lymph nodes. And in terms of spreading, it's confined to the breast and has not gone outside. Also, the 5-year survival is about 100%. Okay. Now, when we look at this stage, and this is a study that was done in the Middle East, where breast cancer generally, it has a much poorer prognosis. It's similar to the prognosis of breast cancer in African populations and Afro-Caribbean, Afro-American population, right? I'll get to that afterwards. Stage 2 is when the mass is between 5 and 2 centimeters. Lymph nodes may be affected by cancer, The spread outside is not there. It's confined to the breast and the axilla. And the 5-year survival, as we see here in the Middle Eastern population, is 87%, okay, at 5 years. In stage 3, the mass is usually about 5 centimeters or larger. Well, 5 centimeters or larger. The lymph nodes may be affected by disease, by cancer, but it's still confined to the breast region, as you can see in the picture here. And stage 4, the tumor can be any size. The lymph nodes could or could not be affected by cancer. But what characterizes stage 4 is that the cancer has started to spread to the organs like the lung, the liver, the lymph nodes above the clavicle or the collarbone, bone, etc.
Now, very, very interesting. I just want to ask Dr. Goodwin. Let's see where we are now. Okay, I want to make sure that I had you gentlemen here. Dr. Goodwin, when you do surgery, what stage are we talking about? Generally, if a woman feels a lump in her breast and becomes concerned, she goes, I'm assuming that there's going to be some kind of biopsy, and if it comes back and says, hey, yes, you are positive for cancer, where do you come in as a surgeon?
Well, okay, that's a little bit of a complex question to answer. But in most situations, if not all situations, at some point in time, somebody who has a diagnosis or suspicion of diagnosis of cancer, you have to have something done in the means of getting some fragment, portion, or the entire tissue that comprises the cancer to test it, to one, confirm that it is cancer, and two, once that is done, you can then look about doing something in the vein of finding some kind of compatible chemotherapy, radiation therapy, some kind of oncological treatment that goes hand in hand with that particular flavor of cancer. When somebody comes to the clinic that they come describing that they felt a lump or a bump or something odd in the breast, we generally start first with imaging studies to get a better idea of what's going on. As a clinician, the best thing you could do is examine the person physically to get a better idea of what's going on. Because though a person knows their body best, they might not be able to convey pertinent information that might be helpful in making a diagnosis. Once you've had imaging studies done to help you have an idea of what's going on within the breast, then comes the part of discovering what kind of problem it is, in the vein of doing either a biopsy, where you take either a fragment of that tissue by surgical means, or that entire lump or bump. Now, sometimes in early stages, if a tumor or a mass is small enough, you're able to excise it completely. But in some situations where things have spread a little bit further, or they've gotten a lot more larger, the condition might be in a state where removing that entire tumor might not be feasible. So sometimes we have to consider, along with the oncology team, the options of giving somebody some kind of chemotherapy to help reduce the size of a tumor, and then later on go down the line and remove a tumor completely if the chemotherapy helps to reduce the size. Before any chemotherapy can be given for a kind of cancer, a diagnosis has to be confirmed by way of taking a fragment from that cancer or from that suspicious tissue to help aid us to have the best kind of treatment, both surgically and oncologically, to have the best outcome for that patient.
So the idea here, therefore, is that if there is a lump, if it is tested and it is proven to be cancer, you discuss with the patient types of treatment, or you recommend the type of treatment. In other words, you mentioned chemotherapy, radiation, and surgical.
Correct.
Are they
Now,
okay, sorry about that. I was just asking, are they done? I mean, do you say to the patient, listen, you can do A, B, or C, or do you? A person may say, I don't want to do surgery. Surgery seems very invasive. So guide me through that. I don't know which one. Yes.
So a long time ago, medicine used to be done based on individual people's experience with different kinds of illnesses. Now today we do something called evidence-based medicine. And the idea of that is that various studies have been done and various looks at different illnesses have been taken, and we've determined that the gold standard of care, or the best practice of management, has been determined to be A, B, or C, or some variation of what the options we have available to us are. There are many roads that lead to Rome, and in some cases, a doctor is able to tailor a treatment plan to a patient based on multiple factors, which would include patient's preference. But in some cases, the best advice that a doctor can give a patient is to undergo a certain kind of treatment. And sometimes patients might be reticent, resistant, or be afraid of even undergoing a particular kind of treatment. And in that case, sometimes we have to find a way to find a middle ground to best accommodate a person, and at the same time do the best thing for them medically for their health. I hope I hope I was able to clarify the answer.
Yeah, certainly.
I do apologize for being public, but unfortunately I've been called. I have to go do some surgery right now.
Okay, well, we are delighted that you were able to make the sacrifice to be here. I will continue with the good oncologist here, and
And thank you
we
for
wish you success
having
in
me.
the surgery. All right. Yes. So Doc, we are left with you, but I know that
Thank
you
you
are
very
quite
much. Have a
capable.
good night, everybody.
Sure.
Thank you, Doc, and good luck on the surgery.
Yes. Okay, so all right, blessings. So Doc, now I don't know if you wanted to add anything to what Dr. Goodwin just said, or do I just move on?
Sure, just a few things. Okay, so the surgery and the treatment of breast cancer will depend also on the stage. Okay. When we're talking about localized stage 0 cancer or carcinoma in situ, the mainstay of treatment is surgery. All right. So you remove the lump completely because the cancer has not started to come out of its shell, so to speak. All right. So it doesn't have the ability to spread anywhere as yet. Okay, it is cancerous, but it doesn't have the ability to spread anywhere. Okay. So you remove the mass completely with a negative margin, meaning if let's say this is the size of the tumor, and I'm going to just use a cap for an example. If this is the size of the tumor, I'll put it here, then we'd have to remove tissue around the tumor like this so that it's not touching on the border of the tumor, for example, here, right? Or it's not close to the margin. So once we remove it completely, we send the patient for radiation. Stage 1 and 2, usually we'll do surgery first, but now recent evidence-based studies, like Doc was saying, suggest that chemotherapy first, followed by surgery, then radiation. And depending on the type of breast cancer it is, if it responds to hormones, we can use hormonal therapy. If it's something that responds to a protein called HER2, which all of us have, but if the breast cancer feeds on HER2 or uses HER2 to grow as a stimulant to grow, then we would block that using HER2 therapy. Okay. In stage 3, usually, most often, chemotherapy is required before surgery can be done. Following that, you'd have radiation, and as I said before, hormone or HER2 therapy. Now, it is important to note that in stage 4 cancer, where the breast cancer has spread outside of the breast and has gone to bone, lung, liver, etc., in those cases, surgery has minimal roles, as does radiation, and the mainstay of treatment would be chemotherapy, HER2 therapy, hormone therapy, or other types of targeted or immunotherapy, where our immune system, the drugs teach our immune system how to identify cancer cells and kill those. But that is, as I said, reserved most of the time to stage 4 disease.
Now, I'm going to ask you, Doc, and I am, I try to speak from the perspective of multiple viewers and some not understanding certain kinds of terminologies. So I want to ask 2 questions. One is the difference between chemo and radiation. But before that, so I asked that first, but that's number 2. I was talking to an individual not very long ago, and this person said, listen, the doctors told me that they captured everything, but still they're recommending chemotherapy and radiation. Why is that necessary?
That is a brilliant question, and the very simple way to answer it, as simple as possible, if that is possible, is when you remove a cancer or when you remove a tumor, even though you get all around the cap, meaning you remove the whole thing and there's negative margin, there's healthy tissue around the mass, right? What ends up happening is, because of the way that cancer grows, it doesn't grow round like this bottle cap. It grows like your typical drawing of the sun, right? There's a main mass in the middle, and then there's pathways where the cancer cells start to grow, kind of like my fingers, like this. All right. So even though you remove most of it, all right, you might leave a little fingertip here, a little fingertip there, or because their cells are so minute and so small, even if you remove all of it with the spiculations, these are called spiculations, right? Even if you remove it with the spiculations, some cells can escape and jump outside of the border of surgery, all right? Also, let's touch radiation first, and then we'll go to chemotherapy. What radiation does, if these cells have skipped the border, basically, all right, and are not identifiable by the pathologist who reads the biopsy or the surgical specimen, you need radiation to burn these cells in the breast so that they don't come back within the breast. All right, so radiation prevents cancer from coming back within the local area. Okay. Also, radiation helps to destroy if there's any lymph nodes that have cells, cancer cells in them. It helps to burn and seal those lymph nodes so the cancer cells can die or won't be able to spread outside of the lymph nodes. Okay. For chemotherapy now, any cancer cell above a 1 centimeter diameter has the propensity of starting to spread through the blood to other organs like the lungs, the bone, and the liver most commonly. Okay. What chemotherapy does, because it's a systemic treatment, meaning you either take it via pills orally or it's in the vein. Because of that, because of the cancer has the ability to go and spread around the system and even have cancer cells in the bloodstream, we give chemotherapy to try and kill as many cancer cells, if not all, within the human body, in order to prevent metastasis or recurrence, a distant disease recurrence. Okay, meaning if a breast cancer cell starts in the breast, as I said before, it can come in the lungs, bone, and liver. What chemotherapy does is it kills these cells that may have latched onto the bone, liver, or the lungs, and decreases the chance of it coming back in those organs.
Now, a viewer wants to know if you develop a lump in the breast and it is proven to be cancerous, can that person say, and how would you, as an oncologist, or the surgeon isn't here now, but how would you advise the person if they say, listen, I want to be very, very sure that I never get this thing again, so can you take off my breast? How do you advise a person like that?
Well, more and more these days, we are deviating away from breast removal. Okay. So in most cases, that's why I had mentioned that almost always now in stage 3 cancer, where the mass is pretty big, we use chemotherapy first, because chemotherapy shrinks the mass. All right. So you no longer need to remove the whole breast. You can just remove that little mass as a result of the effects of chemo. Okay. And that's why radiation is important. So if a mass was this big, the chemo shrunk it down to this big. Remember, it was previously this much, so there might be cells still here that we cannot see, even if we remove the whole mass. We cannot see that there are cells there. There's no need, like before, to do a whole mastectomy or the breast removal. Okay. If the patient really does want a mastectomy, she doesn't want her breast anymore, she's adamant and she's leaning more towards that with the surgeon, then most of the time the surgeon will try to convince her otherwise, but ultimately it is the patient's decision, and there's very little contraindications to removing the whole breast if that is what the patient wants.
Okay, but generally speaking, that may not be necessary.
Generally speaking, that may not be necessary. Now, in a very minute portion of cases, the mastectomy should be done, like in cases where chemotherapy doesn't shrink the tumor and or the breast cancer is latched onto the breast skin, then a mastectomy can be done. Also, another reason to do a mastectomy is if the patient is genetically predisposed to develop breast cancer. A lot of times what is done is a bilateral mastectomy, or both breasts are removed in cases like that. There is a gene that is very much linked to the breast cancer called the BRCA1 and the BRCA2 genes. Okay, so BRCA1 and BRCA2. If a patient has one or the other or both of these genes, then a lot of times the oncologist or the surgeon, the oncological surgeon, would suggest to remove both breasts, and it's called the prophylactic bilateral mastectomy.
Now, can we say a little bit about screening? Because my understanding is, I think this is something that we hear often, early detection is key. So screening, what should a woman do?
Okay.
Yes, go ahead.
So there are 5 pillars of screening. I'm going to be focusing on the 3 main ones so as to not lose the audience. Okay. But before that, let me use an analogy. Okay. I've set up some artifacts here, some objects in order to elucidate, because I've been doing this for a long time, so I know what questions may come.
Okay, sure.
Now let's imagine this is not a breast. Okay. This is a sewing kit. All right. This is a sewing kit. Okay. Now, if we can compare this to a breast, all right, and I'm a woman, all right, as soon as the breasts, so to speak, mature or puberty ends around the age of 20, all right, and the breasts don't develop anymore after that, a woman is suggested to start doing her self-breast exam. Now, why is this? Okay, we know that cancer doesn't happen very frequently in women under the age of 30, under the age of 30 or 40, much less 30. But why we ask women to start with the first pillar of screening, which is self-breast exam, is because if the lights go off right now and I cannot see anything, if I'm always manipulating this sewing kit, if I put my hand inside of the sewing kit, which is not the case for breast, but we can compare it through the exam, then I can know what I'm feeling for and what is normal, what is inside the sewing kit that I can recognize. I'll know that here, this is a bob of thread. If I touch the disc that holds the needle, the pins, I know this is the pin case. I know what's normal within my sewing kit. Okay. So we ask women to start their breast exams at the age of 20 so that they can know what is normal within their breast. So if I do put my hand into my sewing kit and I feel an object that I'm not familiar with, I'm like, wait. This isn't what I'm looking for. This is not what I put in my sewing kit. This is not normal. There's something in here that I don't know what it is. When the light comes on, then I'll be able to look, and maybe my kids might have stuck a little toy in there. In terms of breast screening, women are advised to start at the age of 20 to do their self-breast exam so they can know what is normal in their breasts. And if a small lump is to arise, God forbid, at any point in time during their life, if they would feel it and will be able to recognize it immediately. So that is suggested that women do their self-breast exam starting at the age of 20 every month at least, okay? And that is just so that they can get to recognize what is normal. Number 2, the second pillar that I'm going to talk about, which is the yearly physical breast exam, where you go to your doctor to get a breast exam, is suggested to start at the age of 40 and is to be done yearly. And the third and last pillar of screening that I'll be talking about is the mammography, all right? And that is suggested to start at the age of 40 and to be done every 2 years for women without a high risk of breast cancer, and every year in women who are at a higher risk of breast cancer.
Now, Sam, I'm a man, so maybe I'm asking this question from a male's perspective, but women's breasts are generally lumpy. I suppose you tell them to start early so that they themselves can be familiar and can pick up. But when you mention number 2, you said first is the self-examination, and secondly is going to the doctor to get that physical exam. What is that physical exam? Is the doctor feeling, or is the doctor doing something? Is the doctor going to do? Because I thought you were going to say that being the mammogram, but you said the mammogram is 3. So what exactly is number 2?
So okay, so I didn't list them in order of importance. Okay, they're all equally important and work together. So I did a study. My thesis for my residency was the importance of mammography in screening for breast cancer, or the importance of mammography in early diagnosis of breast cancer. And what I did was I took a sample of patients, of 400 patients that had been diagnosed in all stages, okay? And we plotted and evaluated the importance of mammography, physical breast exam by a doctor, and self-breast exam, and its correlation to pathology results, meaning when you actually get the mass removed, how often it's diagnosed in stage 1, 2, 3, or 4. We found that patients who did all 3, meaning mammography, a self-breast exam, and physical breast exam, which is when the doctor examines the breast for the patient, That's why I always say an experienced doctor, not any doctor that doesn't have as much experience in examining breasts, should do the exam, because what we look for is very specific. 90% of the time when my patients come to me with a lump, with complaint of a lump, they've felt it. Okay. The other 10% is because either I felt it or the husband has felt it. Okay. Now, did I answer your question more or less, or am I missing something?
Yeah, that's fine. That's fine. Go ahead.
Okay.
Now, you just mentioned all the husband felt it, and I wanted to pick up on that. Because again, I asked the men to pay attention to what we're talking about. So how significant is it for the man to be aware of the texture, the feel of the woman's breast?
Well, in most relationships it just happens, because because of the intimacy of a man and his wife. A man is able to, a husband is able to manipulate and get to know his wife's breast as well. A lot of times, a large portion of oncologists do tell the man or the husband, you need to know what you're feeling for as well. So when a woman is taught the self breast exam, the physical breast exam is also taught to the husband, but that is not to replace a doctor who does it on a daily basis and knows exactly what they're looking for, because it is almost impossible for a husband to know the woman's breast as much as the woman herself. You get what I'm saying? So
Yeah.
self breast exam is the first pillar, and the second is the physical breast exam by a doctor.
Now we're almost out of time, but if you can say a little bit more on the mammogram, because again, I suppose that women need to know that this is necessary. People don't like medical treatment, but this can make a big difference in a woman's life, I'm assuming. So you said if the woman is predisposed, does that mean if there is breast cancer in her family, then she should be doing it every year? After what age?
After the age of 40. So yes, high risk patients would be patients who they themselves have had breast cancer in the past, or they have a first degree relative, meaning a mother, sister, or daughter who has had breast cancer in the past, or one single first degree relative with the diagnosis of breast cancer before the age of 40. They would be placed in the high to high moderate risk population, and they would be suggested to do their mammogram every single year, after the age of 40. If a patient doesn't have such a high risk, meaning a familial risk of breast cancer, has been, has not been celibate, or has born children before, breastfed before, then the risk is lower, and they can do it every 2 years. And what a mammography is nothing more or less than a device that spreads the breast tissue evenly and shoots X-rays through the breast, which can capture an image that is studied by a doctor called a radiologist, who looks at the breast on the inside and is able to look at architectural differences, like things called calcifications or white spots on the mammogram, or look if they see a mass or other indirect signs of breast cancer. And they're able to tell us how highly suspicious the finding is.
My last question. So is there if on the male side he can do a blood test, is there any such thing for a woman, or is that on the horizon that she could draw some blood and they study it and say, hey, you have breast cancer?
I mean, I'll be honest with you, there's none right now. It's not like the PSA for men with prostate cancer, for example. But I mean, science is developing every day. There's no reason for me to say now and today that it's impossible for us to find something similar for breast cancer. However, as for now, no, there aren't any.
Okay. Well, Doc, our time has expired. I am so delighted that you were able to make the sacrifice to be with us this afternoon. You have shared a lot of very useful information, very important. I know that you said some things that will make some ladies think. And this woman who may be thinking, I've been delaying my marriage, maybe she needs to hurry up and get married. But thank you so much. Thank you so much.
Sir. It's my pleasure,
Yeah.
Doc. Thank you so much for having me. And if any of the ladies here who are residing in Antigua would like to know what their risk is and would like to ask further questions and meet, I'll share my number, my office number here if you would like, and you can give it to your congregation. I'd be more than happy to assist. It's 778-9999. Very easy. 778-9999.
Okay, ladies, you have that 778-9999. Very easy to remember. Take care of your breasts because it can make a big difference. That's all the time we have. Next week, we're going to be talking about infertility in both males and females. So you want to be on Let's Talk at 3 p.m. next Saturday afternoon. Until then, God bless.